it is feasible to practice guidelines. Nowadays, I have seen in every conference, people are saying as per guidelines, that too, more than the Indian guidelines, they will say as per American guidelines, as per European guidelines, as per Australian guidelines. So if I ask for relaxed uterus, what drug I have to give, what is the dose? Then they may say, as per Australian guidelines, it is 10 units oxytocin. As per American guidelines, it is 20 units. So we don't know what to practice. So really, I want to bring some insight whether it is really feasible to practice guidelines, and in what are all the ways the guidelines are hindering our practice as well as our progress, especially in a group practice. I want to keep the discussion as very simple so that we can interact at the end. The first problem I have seen in these guidelines is lakes of lakhs. So many problems are there, and I want you to think over it, because as a Ozone group, you can form your own guidelines, taking it into your mind. So the first thing is, many people are not aware of the guideline and they are not familiar. For the simple reason, these guidelines are circulated through WhatsApp, and guidelines are circulated through social media. And even if the textbook it comes, it will be so many flow diagrams, everything. And people may not be aware of the intricate things in that. Then, as I said, the Australian guideline will not go with the American guidelines. It will not go with the European guidelines. And unfortunately, I have seen all the Western countries, they are having their own guidelines, and India is not having any guideline. But Indian guidelines is only one thing. They will safely anesthetize and recover the patient. That is a one and only guideline India has, and India has succeeded. And sometimes I wonder whether this insertion of guidelines by the Western people is to keep us a little bit lower down, that you have to follow guideline, you have to follow guideline. But we are also practicing anesthesiology when the guidelines were not there, and we have safely anesthetized and we have safely recovered the patients also. So the lack of agreement in the guidelines is another problem. Then I cannot say whether the guidelines are really efficient. If I practice guidelines, whether it will improve the outcome or it will overburden my thinking, that is a problem. Another one, if the guidelines say something, that is, you practice this, then I have to be a master of that. For example, I'll say if the guidelines say you perform ultrasound guided brachial plexus block for a upper limb surgery, when I am not having ultrasound, or if I am a senior who is not exposed to ultrasound guided nerve block, when I am comfortable with the general anesthesia, whatever complications the patient may have, then I will go for general anesthesia only, because in my place, in that particular area, only that is possible. So if the guideline says, if there is upper limb surgery, you have to perform first nerve block, that is ultrasound guided nerve block. If it is not feasible, then you go for general anesthesia. Means it is really tough. And all the guidelines says all the people should have the same skill. It is very, very difficult, and the same level of skill and experience. Training may not be there. Corporate medical colleges, the training may be different because they may have all equipments. But in small medical colleges, the skill will be the same. They will really anesthetize, but the training will be less in the sophisticated equipment. My next question is, right, I am following a guideline. So if suppose the guideline says, if you could not mask ventilate, you insert a LMA. And if I am not good at inserting a LMA, then who will come for my help at the time of this guideline recommendation? But I am good at endotracheal intubation, so I can intubate the patient immediately. So possibility to save the patient, but the guidelines will create a hindrance in that. And one more thing, if I am sticking to the guidelines, strictly, and if I am reading that, that will erode my confidence level, because I will again and again think if it is not there, if it is not there, if it is not there, that is a confusion. And another one, even if I do all those things, whether there is any guarantee that the outcome will be improved, that we have to think. Again, the lack of practice, because so far we have not practiced any guidelines. So suddenly, if the guideline comes and if I am ordered to do so, then it will be a problem. I will come back to it later. Why I say lack of awareness and familiarity? Like a blind man searching, describing an elephant, we are following the guidelines because nobody knows the intricacies of guideline. And if I ask anyone to enumerate how to do that, then they will get stuck. Then they will recollect only from their practice. Nobody can tell from the memory that if plan A is not working out, plan B is not working out, plan C, and suddenly another guideline will come. If the plan B is partially successful, what we have to do? So if plan C is partially successful, what we have to do? So that is a problem. And so nobody is familiar with the specific content of the guideline. Another one, when we are reading a guideline, when we acquire that knowledge, there are so many barriers related to that knowledge. And as I earlier said, the guidelines are circulated only through WhatsApp and it is in group. And how many people are reading the WhatsApp messages in a group, I don't know. And even if we read that, how far it is applicable in the real practice, I don't know. Another problem is there is tough argument where to go. That means there is no consensus in the guideline formation. Every time the guideline have some if and buts. So the barriers are related to attitude of the people. And even the research says there is a lack of agreement with the guideline recommendation. That is 68%, they have an attitudinal barrier. And applicability is another problem because the pros and cons of following a guideline is to be weighed. And as on date, I have never found following a guideline, it will improve the outcome. See, following a guideline means it is a consensus of the knowledge which we regularly practice. If Aurangabad anesthetist is also doing the same thing, if I am also doing the same thing, then conferencing is not at all needed. The idea of conferencing is to know how you practice, how I practice, and we have to exchange the good philosophy and the good principles. If it is not there, and if it is the same everywhere, the management is the same, then life will also be boring. That we have to consider. If a patient is obese, then that recommendations will be different. If the patient is thin, that recommendation will be different. Then there may be so many comorbid conditions. So we are simply saying nowadays the airway algorithm is the most popular guideline, but that airway, every time there will be a deviation. So if the patient is having a mustache, then you have to have a separate guideline. Being a member of airway society, we cannot intubate. That is a problem. That is the reason why I fear it will erode the confidence. See, if all are like this, then the uniformity will kill us. It will be boring. It is not only for life, it is for anesthesia practice also. So if the life is different, if anesthesia practice is different, then it will be colorful, it will be attractive. But only one thing, we have to safely anesthetize and safely recover the patient, and that we are all doing. So if the dresses are uniform, it may not be good always. If the dresses are multiple variety, then it will be attractive, but the principle is the same. It has to cover the area which are intended to be covered. Recommendation is not applicable to the entire population. It is applicable only to a specific group, and the difference is always needed. See, if that uniformity is like this, it will be like a Xerox company. it will not be quite good. But if it is different, practice is different, then life will be interesting. So we need not have a uniformity. There may be deviations. Regarding the attitudinal barrier, as I said, there is a lack of self-efficacy. I cannot guarantee outcome if I am following specific guideline because of lack of skills, experience, or training. And if I am not trained in one particular skill as an anesthesiologist, I can go to the next level. Just I mentioned, I may not be good at inserting a LMA, but I can intubate because of the experience, the senior anesthetist, without explaining what to do, they will intubate. Even I have asked my chief, whenever at that time when I was doing my post-graduation in 1989, when we could not intubate, we will call the chief and he will come and intubate. Once they asked him, sir, how you are intubating when we could not? Then he used to say, Array, you will also do it one day. At that time, you may not be able to tell how you have done it. The same thing is happening now. Without informing the intuition, we are intubating the patient. And now they say there is a PERT maneuver, this maneuver, that maneuver, all guidelines. So when you are in crisis, if you are thinking of guideline, then your time will be wasted. So if you are good at alternative technique, then we have to switch over to that immediately rather than wasting time by strictly sticking to the guidelines. That's what I feel. Another problem, as I said, if the plan is not on the expected line, just for a easy example, I have mentioned that LMA and ETT. So if I could not insert LMA, who is going to come for that? So in the guideline says you have to do LMA. If it is not possible, then only you have to go to ETT or you have to go to endotracheal tube. If it is not possible, you have to come back to LMA. Who is going to guide at that line? Then that epidural, now segmental epidural has come, segmental spinal has come. When I am not good at those things, then the guidelines may create more of a confusion for that particular anesthesiologist. So we all should agree a man on the spot is the best judge to decide the type of anesthesia and the guideline for that particular patient for that particular area. See, I'm not against the guidelines. What I want to convey, just because you are not aware of the guidelines or just because you could not follow the guidelines, you need not worry about it. Even if I follow the guidelines, they cannot guarantee a better patient outcome. No guideline has mentioned if you follow the guideline. See, it is just a ready reckoner. It is a ready reckoner, but our brain is a ready reckoner. We have been managing all the complications. But in the guideline, they say you try dopamine. If not possible, go for dopamine. If not possible, go for noradrenaline. If it is not feasible, then go for vasopressin. The methodical thing, if suppose something is not available, then you will get stuck. And we cannot theoretically say patients are same everywhere, life is same everywhere. So we have to have all the infrastructure necessary so that we can anesthetize, or else we should not anesthetize. It is not like that. See, the infrastructure is decided by the available resources. Available resources, and it is according to the particular place concerned. So, if you are good at administering a safe anesthesia at that particular point, then we can proceed with that. As a qualified person, we know which is a basic infrastructure and which is a greedy infrastructure. So I cannot say without a BIS monitor, I cannot anesthetize a patient. So we should know what is required. Oxygen source is required, nitrous oxide is required, some basic thing rather than having a TEE or a BIS monitor or a robo-assisted anesthesia, that and all, we can say if suppose one robo precisely does that, we cannot form a guideline that you have to have a robo everywhere. As we are trained so many years for so many years in some particular technique, it is very difficult to change all on a sudden. So we can ask the juniors to follow something which is feasible But even then they will be overstressed. Already the postgraduates are saying that they are overstressed. So adding a guideline itself is going to give more stress. And we all know old habits die hard, right? But old is sometimes gold. I cannot say every time it is like that. Why I am saying gold is gold? Without a guideline, we were practicing for all these years, and we have succeeded in anesthetizing and recovering the patient. That is a basic take-home message I want to give to infuse confidence, even without that, because now only the bougie, your video laryngoscope, everything has come. So in the guideline, they say if it is not possible, go for that. I say it is only a training. So automatically, if you could not visualize the glottis by laryngoscopy, automatically you will be switching over that. That is your reflex phenomena. So by one following is very difficult, because step by step is sometimes possible. Sometimes jumping 2 steps above is also possible. So think, you have to save the patient. So what I want to convey, if it is a butterfly stroke or a breast stroke or a reverse stroke, swimming may have so many guidelines, but the only principle behind it, you have to reach the shore safely. That's what we all have been doing. So the anesthesia is just like swimming. The methodology may be different, but you have to reach the shore safely. And why I am arguing this much against the feasibility of the guideline? See, the guideline should be short, then only it is easy to understand. It should be a one-word thing if it is not possible. But the challenge is to produce a simple guideline, because the patients are having complex phenomena, multiple comorbid disease. They should address the complexity of the problem. So what I want to convey, it should be simple. At the same time, it should be able to address the complex problems the patient has. So it should be simply complex. So the simply complex means it is very, very difficult to enumerate what are all the factors to be included. If it is simply complex, then anybody can follow. Till that time, it is very difficult to adhere to the guidelines. Guideline recommendations are in multiple format, because one is in algorithm, another is flowchart, another is pie chart. See, if you see the textbook, that entire one page will be full of these diagrams, some rectangle or square, then so many arrows, then every circle have 2 or 3 arrows. How you will remember that? Because in acid-base balance and this electrolyte imbalance, the same thing happens. So if the guidelines are in multiple format, then we have to think like this monkey, which has to be practiced. That is more confusing. We have to scratch our head, because the guideline recommendations are available in algorithm and 1 or 2 page summaries. You just recollect what you are seeing in the textbooks. So there may be some electronic versions also. Now they are putting the animated thing. So then they will give you a hyperlink. If it is not possible, you go to that algorithm. So that is a problem, because they wanted to address the varying needs of physician and the patients. That is giving us more confusion. If the guidelines are like this, volume 1, understanding a woman, if this is very big, it is very difficult to follow. Nobody will touch and nobody will read it. Nobody will follow guidelines if it is tough. So, and another thing, you cannot form 1 or 2 line guideline, because it has to address all the problems. So we have to read it instead of reading it as a flow chart. Then by forming a guideline, the external barriers are from administrators like me. The problem comes, the administrator has to cooperate to fulfill the guidelines. The logistic problem during the regular working hours and during emergency. So sometimes some fancy articles will be kept in a cupboard. It will not be available in emergency. Sometimes only the emergency theater will have all the drugs, and elective theaters will not have all the necessary equipments, whether it is elective or emergency during the working hour. In emergency, when you are anesthetizing the patient, simultaneously you will anesthetize, and at the same time you will be looking for the infrastructure. We cannot predict whether everything is ready. And I cannot theoretically argue, no, if you start a case, you have to keep everything ready, right? It is applicable for an elective case. In emergency, when I want to save the patient, I will start simultaneously, I will check at that time my assistants, whether they are qualified medical assistants or the theater assistants, they have to possess a real skill. So that lack of communication and a lack of skill among assistants, it will create an obstacle in following the guidelines. And between organization means, if the guideline says, if there is a BP drop, you consult a cardiologist. If the guideline says, then if the cardiologist is not available there, what we will do? That is the problem. Why all these things are problem? I will come. That is a main point. Why I am worried. I am not against guidelines. I stress I am worried about the guidelines. I will come to that point, vital point. Tasks are not divided between the departments. And again, till the cardiologist comes, who will manage the patient? So the lack of time, lack of resources, they are the external barriers in following the guidelines. And that applicability problem, see, applicability is really a problem because we have to have all the necessary infrastructure mentioned in the guideline. And I want to know, when it is not being applicable due to the different population, why we have to follow that? If there is a airway problem, that airway problem will addresses only the airway, that guidelines. But if the same person is having hypertension, at the time of laryngoscopy, the stress response will be more. It will not be addressing that. That is a problem. So the person standing at the head end of the patient knows everything about the patient. So he has to decide. So in nutshell, I want to say, guidelines can only guide. They will not be the complete anesthesiology. So if you are not able to follow the guidelines, you need not worry about it. And each key recommendation has a unique combination of barrier. That is a problem. And every time if there is a barrier, just as I said, if the patient is obese, if the patient is hypertension, if the patient is diabetic, then multiple interventions are needed. Again, that guideline itself will be just like reading a textbook. That is what exactly we have done. If the guidelines, every year you see 8 to 10 guidelines are minimum coming from different country. So altogether every year minimum 20 guidelines will come. So if there are too many guidelines, which is to be followed, we don't know. That is a problem. And another problem is even that updating the guidelines, because we say the American Heart Association 2000 recommendations, American Heart Association 2010 recommendations, and we have created a feeling that if you are not updated with the guidelines, you are having a lack of knowledge. That is a problem. That is the Western intrusion, I feel. If you are not good at updating, this is just like updating our iPhone, updating our Android phone. Every time they will update, at the one point, it will get stuck and person will say, sir, the hardware is not supporting the software update. That is the idea. See, how come every time they change? So only the practice changes everything. At that time, we were giving 120 compressions. Then it was made as 100 compressions. Then the diabetes, initially we said fasting blood sugar less than 120. Then we said 100. Now the fasting blood sugar has been made as 90. The diabetic population in India doubled. And if you bring it to 80, then it will be tripled. So who decides? Every time we say the practice changes the guideline. So then what happened to all those people who have undergone the same treatment which was prescribed in 2010 guidelines? Imagine. So that is a problem. And because it has so many problems like this, the public are saying, what, sir? He is saying like that, and you are saying like that. That is the confusion. So our reputation is also eroded because the guidelines are made public. That is the only thing. Textbooks we are reading, because of guidelines, everybody is asking, why you have not followed that? Why you have not followed that? That is a problem. So if we have to follow only the guidelines, then PG courses need not we need not have any postgraduate courses, because a robo can be trained in following a guideline. But as a human being, I want all of us to apply our brain. Even in the anesthesia assessment clinic, I used to say, people will say it will be a case of hemorrhoid and hemoglobin may be 7.7 or 8. Then the anesthesia PG will reject it because the hemoglobin is less than 10. See what the guideline says. If the elective surgery, the hemoglobin is to be 10. For a hemorrhoid, how it could be? Same way in a DUB, just for a check curettage or for taking a biopsy, these people will be transfusing blood because they will say we have to have a hemoglobin of 10. So I used to convince them, you apply your brain. If the hemoglobin requirement is 10, then I can place a robo, you can come and you can enter your data. Once the data entry is made, the robo will give a slip, you are rejected, you are accepted. So it should not be like that. If we have to follow the guideline, the postgraduate can read it as a notes. Then that technical training regularly for 3 years we are teaching them, that is not needed. And most of the time we will have some mnemonics during our post-graduation time. Everybody will have mnemonic. Then at one point of time, there was a book for mnemonic itself that will have 100 pages. Then to remember that mnemonic, you have to have another mnemonic. That is problem. So if everyone's name and face are the same, like practice, then it is this world is not a thing of beauty. It will be treated as a big Xerox company, as I already said. The patient factors, if you follow the guideline, even in evidence-based medicine, they say you have to convince the patient about all the available treatments. Then the patient has to select which treatment he likes. Imagine how many of our patients are knowledgeable, they can interpret. How many of us are having internet? How many of us are having social media acquaintance? So that is a problem. And even if you explain for 45 minutes to the patient, everybody knows what answer they will give. Sir, whatever you feel it is good for me, you please do it. So it will be a wastage of time. Then you will be thinking for explaining all the complications. So the patient factors, see, it is the patient expects a sky high level quality care, sky high level, but he will not pay for that sky high level. And just because the patient is in the sky high level, the clouds will obstruct the view of the practical atmosphere. And practically, we are living in this sort of a problem. So if the guideline says in an emergency call, the anesthesiologist should reach within half an hour, then if you are not an in-house anesthesiologist, it is not at all possible for you because the ground reality is different. What I want to convey, patients' preferences may not match with the guidelines. That is what I want to emphasize. And patients will not follow any guideline. We have to follow a guideline. So if the guideline says you have to visit the patient 10 days post-op, after 10 days, there is a post-operative period, the patient may not turn up because there is no guideline for the patient. The guidelines are for us only to get more torture. Another one is the ego clash. This is for fun, I am saying. If a PG has to learn from the chief should behave like a chief. Even so many chiefs would have taught some wrong techniques to the postgraduates, but the postgraduates will follow the same. But if there is a established guideline or established evidence-based medicine thing, then the PG can question the chief. Sir, it is mentioned like this and you are saying like this. That will lead to a ego clash also because boss is always a boss. Even if he is Gorilla, boss is always a boss. So till that postgraduate time, we have to follow the orders of the boss because the boss is always right. That is the dictum. And I want the rule number 1 says the boss is always right. But rule number 2 says if you feel the boss is wrong, again see the rule number 1. That is boss is always right. So the guidelines are creating a problem there also in day-to-day atmosphere because to follow the guideline, nobody should have an ego. That is very difficult in a human mind. This is what I want to emphasize. If the guidelines are published, legally, we are responsible for that. This is the ultimate point I want to emphasize. Why I am worried, even though I am not against guidelines. If the guidelines are there, the court can easily question. If it is not so, you have to do this and you have not done that. That is a legality. Because guidelines are framed by a body of experts. It is a professional body. If ISA is forming a guideline, compulsorily it should be followed. So even our ISA has formed a guideline about preoperative assessment. I talked about it in Pune. And see how much it is difficult. See, for a preoperative investigations, they say the echo need not be repeated for 6 months duration. Any recent test, it is applicable for 2 months duration. Another thing, for simple surgery, for intermediate surgery, for major surgery, they have divided 3 types and they have given some 8 examples for the surgery. That is for a ordinary surgery means it is just like cataract, hemorrhoidectomy, hernia, intermediate surgery, then major surgery. Then every time they say for major surgery, you do LFT, that one, this one. Then for intermediate surgery, you need not do that much. ECG is not required as a routine. X-ray is not required as a routine. So if you are writing an X-ray chest for a patient undergoing herniorrhaphy, then you will be under a problem, legal problem. It is not mentioned in the guideline. Then you have unnecessarily wasted the patient's money. But they say the X-ray is not needed. The X-ray is needed for a patient who are complaining of respiratory symptoms, recent onset of respiratory signs. See how much difficult it is to write a X-ray chest. If I have so much guideline, then imagine my problem. Then the hemoglobin, if it is a hemorrhoidectomy, the hemoglobin will be 8 only. Once that hemorrhoidectomy is done, then the hemoglobin will improve. So the main problem will be every time. See, once I finished that lecture, a delegate asked me, sir, if the 30-year-old man coming with cataract, who is already fit, what tests you will advise? Can we take it up just like that? Then I said, right, it is going to be done under topical anesthesia only. You can straight away take it. That is my opinion. But that they say, sir, without any test, how we can take the patient for surgery, sir? That is the guideline. See, even the patient requires something to be done before the surgery. See, even for a retrobulbar block, nothing is needed, no test is needed. Just imagine, even though it is very difficult to accept, it may not be palatable. Now these people are doing under topical anesthesia, ophthalmologist. Then why there is a need to test everything, blood, TC, ESR, urea, sugar. Sugar at least you can check because diabetic level you can control. Unnecessarily, if you are performing everything, guideline for preoperative testing means then guidelines for intermediate surgery, everything will come. So the legality is a problem. So the guideline recommendations, as it is unclear, as it is not covering the relevant information, and it is not being up to date every time they say. So it is not easy to practice. So now imagine if you ask me to come to Aurangabad, you just say, come to Aurangabad, then I will come. So if you say you travel from Tanjore to Chennai by road, if not possible by train, if not possible by flight, then reach Hyderabad flight. If not possible, then in algorithm, if you could not catch the flight, travel by train, collect your baggage, then come out, wait at a restaurant, the person will come for pickup. If you say this much just to come to Aurangabad, then I will not even start. I will be in my place only. It is very difficult. So even you cannot give guideline for everything. And every time it will not be feasible for me to follow guidelines. I will reach somehow. I will reach somehow. So as a qualified person, I should have the clear idea how to do that. So everything cannot be dictated by someone. So if you ask one to marry, then you have to say you marry an intelligent or a beautiful girl. So instead, if you give a guideline that nose like Katrina, eyes like Karina, hair like Aishwarya Rai, legs like Padukone, hands like Sunny Leone, then it will be ugly. Then it will be ugly. So every time the guideline will not work out. So if you say with all these qualifications, the brain should be like Aurangabad anesthesiologist, then it is be very difficult because they are extraordinarily intelligent. So that is a problem. So we have, once a girl has to marry a boy has to marry a girl, only that much. Every time if you give a guideline, it will be a problem. So following a girl is easy, but not a guideline. That is, as far as we stand today, I feel it is very difficult to follow the guideline. So when I will follow a guideline, a good guideline should be like a good speech. Then you may be asking me, what is a good speech? A good speech, according to Winston Churchill, a good speech should be like a woman's skirt. It should be long enough to cover the subject, but short enough to create interest. So a guideline should have some lacuna so that it should create interest. So if I want to follow a guideline, if we want to frame a guideline, you can write whatever you like, but at the end, in administrators, we know when the job functions are allotted to the subordinate, so many job functions will be allotted, maintaining the record, maintaining the statistics, maintaining so many things. That last point will be any other work assigned by the superior. Any other work assigned by the superior will be the last line. Same way, whatever guidelines we frame, the last line will be the qualified anesthesiologist anesthetizing the patient can take a stand based on his experience. That should be the last line, because the anesthesiologist available on that particular spot is the great judge and the best judge. So all guidelines they are followed. Any other thing felt good for the patient by the concerned anesthesiologist, then only the guidelines will be followed. Till that time, it is very difficult. It is not feasible. It is not easy to follow a guideline. So I thank you, Ozone Group.